The broadcast is now starting. All attendees are in listen-only mode.
Good morning or afternoon, everyone. Thank you for joining us for our webinar. It's a more granular approach to revenue cycle, digging deeper into specialty reimbursement niches. My name is Pam Jones. I'm with MCOT. I am the co-chair for the Programs and Education Committee for the Tennessee HFMA. I have a few announcements to make before we get started. We have posted the slides to our website, and you can find the link in the GoToWebinar chat box. And registration will be open shortly for our next webinar entitled Making the Supply Chain Your Competitive Advantage in an Era of Bundled Payments and Population Health. And that will be held on June the 14th. So please check back at our website for more information later on. And also, registration is still open for our Spring Institute, which will be held next week, May the 16th through the 18th in beautiful Franklin, Tennessee at the Embassy Suites in Cool Springs. And the schedule contains a great lineup of speakers, educational topics, and panel discussions. So please go to our website, TNHFMA.org, for more information and to register. And just a reminder, in order to be eligible to receive the CPE credits, you must be connected to the webinar for at least 90% of the duration, and you must respond to at least 2/3 of the polling questions. And now I would like to introduce today's speaker, Chad Powers. Mr. Powers has worked for Franklin, Tennessee-based Medical Reimbursements of America, Inc., MRA, for more than 6 years. In his current role, he serves as General Counsel and manages the legal department and compliance at MRA. In addition to his corporate legal responsibility, Mr. Powers advises on operational issues including managed care, ERISA, Medicare, Medicaid, MSP compliance, workers' compensation, third-party recoveries, as well as HIPAA compliance. Given the complexity of changes in healthcare, Mr. Powers provides education and training events to professional associations in the industry and to hospital employees nationwide. So I would like to turn it over now to Mr. Powers.
Thank you so much for that introduction, and thank you all for attending today. I will tell you this, I don't know if you all know this or not, but I'm actually the guest speaker today, so I want to go ahead and ask forgiveness ahead of time in the event that I stumble through a couple of these slides. I've been through this presentation a number of times practicing, but I can tell you that I'm not the one that created it, and I'm helping out because something came up for Michael Ford, who was going to present today. So your forgiveness is appreciated as we move forward. What we're going to talk about today is a more granular approach to revenue cycle, digging deeper into specialty reimbursement niches. That sounds like a really fancy topic, but what we're going to talk about today is looking at some of those what we call specialty reimbursement niches inside your outstanding AR that could potentially result in you picking up some significant additional dollars. Now, I will say this, I always put this disclaimer on all of my presentations. Don't hold it against me, but I am an attorney, and as a result of being an attorney, there are some slides in here that reference case law and some laws and that sort of thing, but I do like to put this disclaimer in that this is just general information. It's not necessarily legal advice. So if you do have legal questions, you need to consult with your in-house counsel or outside counsel, whatever that may be. So all of that being said, let's get started. More than ever, and I'm going to try my best, guys, not to read this to you, more than ever, hospitals are under a lot of pressure to maximize reimbursements, to bring in money, to be able to pay the bills and keep the lights on, right? And there are a lot of, I guess, a lot of obstacles that are out there now with laws changing and with contracts, your payer-provider contracts that prevent you from being able to maximize. As a part of the ACA, we have 16.4 million people that are newly insured. And while a lot of hospitals or a lot of people think, wow, that's great, we continue to see that medical spending is outpacing the actual reimbursement rates. Your reimbursement rates are deflating pretty quickly. We're seeing that your Medicare and Medicaid reimbursement rates are going down. Your commercial carriers are coming in and negotiating much more rigorously and getting much lower reimbursement rates. I'm sure your contract management department is seeing that. The argument is that, even though it doesn't seem this way, the insurance companies are not making as much money as they were, because now they're having to insure higher risk individuals. We're seeing an increase in payer and provider consolidation. We're seeing a lot of the big hospital systems that are coming in and gobbling up the smaller facilities. We're seeing payers buy one another. We saw the big Anthem deal that went down, Anthem Cigna deal that occurred, I guess, late last year, early this year. And so that is going to make those guys have more bargaining power as they move forward to basically pay lower rates to the hospitals. Because of the ACA, we're seeing more what we call consumer engagement into the patients are getting more involved in their health care. They're going out to the marketplace and they're able to choose what plans they want. There's more than 145 million individuals that now have insurance via commercial health insurance plans. As a result of that, however, in an effort for the insurance companies to save some money, we're seeing high deductible plans. Since 2012, we've seen high deductible plans. We've seen that they've doubled. So what does that mean for hospitals? And we're going to talk about all this as we go through the presentation. Obviously, this is just the introduction, but what we're seeing is that's going to lead to a much higher percentage of self-pay dollars that are out there. Our experience has been that when you have self-pay dollars that are sitting out there, you typically get a reimbursement rate of 3 to 5%, and maybe that's being generous on those self-pay dollars. That's 3 to 5 cents on every dollar that you're seeing. And these high deductible plans, people are being put in a position of having to pay for insurance now, and then if they have a high deductible plan, it puts them in a squeeze. You're even looking at middle or median income individuals that are having a hard time covering their medical bills on these high deductible plans. We're seeing information technology. Here's the deal. Here at our company, we're having to invest a tremendous amount of resources into our IT department just to keep up with compliance regulations. HIPAA and high tech requires so much now from just an encryption standpoint, from encrypt all your mobile devices, encrypt all of your emails. If you have PHI, everything that's sitting at rest, all of your data has to be encrypted and preferably off of your network and not available there's the minimum necessary. How do you prevent phishing? How do you track it to make sure people aren't phishing for information? There's so much that, from a cost perspective, that goes into maintaining all of that PHI, which takes away from your bottom line. And then how do you track all of it? Well, you don't. And that's an unfortunate reality when it comes to hospital business offices, is that quote-unquote big data is still not available. Now I can tell you there's systems out there, as the billing systems and the AR systems are developing, like Epic and some others, there are some definite tools that they're incorporating into those systems that are helping hospitals track some of the key performance indicators that they need to. But as a whole, big data is largely still out of reach as a strategic tool. So what does that mean for hospitals? It basically means that focusing on what we're going to call traditional indicators of a healthy revenue cycle are no longer enough. So what do we call traditional indicators? Traditional indicators are your commercial, it's basically your financial classes. You have your commercial, your Medicaid and Medicare, which may be lumped into government, self-pay, and other. So we're looking at 42% of your, on average, of a hospital's outstanding AR sits in the commercial insurance bucket. As we talked about before, we're seeing consolidation of these payers. We're seeing payers come out and say, hey, we've got to negotiate better or lower reimbursement rates because they're feeling the pressure from having to insure high-risk people. So you've got 42% of your bucket that the reimbursement rates are going to be going down. We know for a fact that Medicare and Medicaid at 27 and 18% respectively, those reimbursement rates have dramatically dropped. And there's not a thing you can do about that. If the government mandates they're going to drop the reimbursement rates, they're going to drop the reimbursement rates. You can accept it or not. Self-pay sitting at 9%. Quite frankly, I think that bucket you're going to see grow and grow, and you're going to see the commercial shrink, and you're going to see the Medicaid grow a little bit as we see more and more individuals getting insurance as a result of the Affordable Care Act. And those self-pay dollars, as we talked about, just don't produce revenue. They produce some, and we all know that cash is king, and it's great to get those dollars in, and it does help pay the light bill. But reality is, on that 9%, which will be growing, you don't get a very high reimbursement rate. So that leaves this little orange triangle, the 6%, which is relatively small as far as your entire AR, outstanding accounts receivable, is concerned. But that 6% all of a sudden becomes about the only place that you can increase or have the ability to potentially increase your reimbursement rates and figure out how to get more cash in the door. So what falls into that other bucket? Well, we see workers' compensation, we see out-of-state Medicaid, other government plans like VA, TRICARE, we see automobile no-fault insurance, and we see automobile liability insurance. Now, I'm going to go ahead and tell you there's a big difference in no-fault and liability insurance. We're going to go into that a little bit later in the presentation, but I want you to keep in the back of your mind that those are separate insurances. They're both automobile insurance. I have yet to see a hospital that separates them from a financial class perspective. I wish you would. I wish somebody would. It would benefit you greatly. Nonetheless, what we're going to focus on today is that little specialty niche there with no-fault insurance and auto liability insurance. Because as you can see, as a whole, that represents about a third of all of the quote-unquote others. So it's a third of your 6%. And we're going to talk about how, if you do focus on those, how you can potentially increase your reimbursements from that perspective. So again, focusing on no fault and focusing on liability, it may not seem like it's worth it because, again, it's a third of 6%. So I'm going to sit here real quick. I haven't done this yet. Is that right? Let's see. We got 6%. So that's about 2% of your overall outstanding AR. 2 to 3 is what we generally see. So it's not much, but I can tell you that the dollars that are sitting in there are significant. And that's what we're going to talk about today. So let's look at a few facts regarding motor vehicle accidents in those accounts. Before I do, I know that you all have 3 questions that you all have to answer, so I'm going to hand it back over. And if the first question, I believe, if you'll go ahead and ask that, then I'll stand by and then we'll move forward with the presentation.
Okay. Let me do that real quick. The first question is, what percentage do non-traditional payer sources represent of a typical hospital's revenue? And just a reminder, you do need to answer 2/3 of these questions to be eligible for the CPE. So I'll give it just a few more seconds and let everyone have an opportunity. Okay. It looks like the majority of everyone said 6%. That came in at 81%.
That is correct. All right. Do we want to move forward or do we need to wait on some others?
No, that I think that'll be good, and you can continue.
Okay, perfect. So here are a few facts regarding motor vehicle accidents that I think you should know. 2015, there were 14% more motor vehicle accidents than in 2014. Oh, sorry guys, I got on a different monitor and it didn't click. Patients treated as a result of an MVA represent a higher percentage of the self-pay volume. In 2013, almost 25% of MVA-related accounts had no commercial or government help. So a quarter of the people that come in and treat at your facility as the result of being involved in a motor vehicle accident don't have, at least in 2013, had no commercial or government health. So you're looking at a quarter of those are simply self-pay dollars. And if you recall what we talked about, you're looking at, again, about a 3% reimbursement rate, 3 cents on the dollar on those self-pay accounts. In 2013, the P&C industry, that's property and casualty insurance, for those of you that don't know that little acronym, the P&C insurance industry paid out $30 billion in medical claims for motor vehicle accidents and work comp injuries. That's $30 billion that got paid out. Now you need to keep in mind, that's part of that $30 billion on these MVAs was paid out directly to the patient and most likely never made it to the hospital if you don't have processes in place to identify those automobile accident insurances. And that's something we're going to talk about today. The Insurance Research Council reported that in October of 2015, the average cost per bodily injury claim from an MVA increased by 32% from 2005 to 2013. It went from $11,738 on average to $15,506. The average cost of a PIP claim increased 38.2% from $5,802 to $8,017. The PIP is a no-fault insurance. We're going to talk about this a little bit later, personal injury protection. And we'll talk about what that is, but it's an automobile insurance. And basically, the cost that they've had to pay out per claim has increased 38%. Lastly, attorney representation in these motor vehicle cases increased 31% between 2007 and 2012. to around 50%. And what this means is that now half of the individuals that are involved in motor vehicle accidents now retain an attorney to assist them. This is important because once a plaintiff's attorney or the patient's attorney gets involved, that attorney is representing that patient's best interest. So that patient's best interest is as much money in that patient's pocket as possible to pay for future medical bills and to make sure that they're taken care of. Sometimes they're disabled. I mean, there are very real reasons that they need that additional money in their pocket. But the way that they get more money in the patient's pocket is by understanding lien laws and understanding legal arguments and coming to the hospitals and saying, you need to reduce your bill and accept this reduced amount as payment in full. We're going to talk a little bit about that today too. So, question is, are you interested yet in pursuing motor vehicle accidents? Let's look at a few more facts. As we talked about, auto accident and work comp specialty reimbursement categories represent an average of 3% of a hospital's revenue cycle. Of 5.7 million police reported crashes in 2014, 2.5 million of those patients went to the emergency department. 10% of those were hospitalized. As inpatients. So that means of that 2.5 million, 10%, 250,000 were inpatient claims. Auto-related injuries result in $18 billion in medical costs. So as you can see, you think about $18 billion across the country and think about the fact that you can get significantly more from a reimbursement rate perspective from auto insurances. $18 billion in medical costs is a lot of money. The average cost for inpatient hospitalization for an auto accident is approximately $57,000 in total health expenditure over the person's lifetime. Remember that 10% of those 2.5 million, approximately $250,000, had to be treated in the hospital as an inpatient, and the average per patient is $57,000. More than 85% of employers are now considering or have implemented greater employee cost sharing. And why is that important? Well, we talked about that. We talked about the fact that we're having high deductible plans. We now have ERISA plans out there. More and more companies are going to a self-insured model. And when you go to that self-insured model, a lot of them will mandate that any third-party payer is primary, which could be auto insurance, NoFault, MedPay, or it could be auto liability, depending on how that plan is written. So in addition to that, even after you bill that health insurance, we're seeing these high deductible plans. We're talking about $5,000, $10,000, $20,000 deductible plans that we never have seen in the past. So that is, and I apologize, I'm off on my numbers on my notes, so that's why I keep looking over and getting a little confused. Okay, got it now. So that's why I kept getting ahead of myself, isn't it? So what we're seeing is high deductible plans. They're becoming more and more prevalent in addition to more self-insured plans. So at this time, Pam, I'm going to go ahead and I think that you can ask question number 2, and we'll see how the people answered that one.
Okay, the second question is the average cost for inpatient hospitalization for an auto accident is approximately $5,000, $23,000, $36,000, $57,000, or $64,000. And just an additional reminder that you do need to answer the questions 2/3 in order to get the be eligible for the CPE credits. So I'll leave this open for just a few minutes longer, few seconds longer rather. Okay, it looks like 14% said 23,000, 16% said 36,000, and 68% responded 57,000, and then 3% responded 64,000.
Great. Am I supposed to tell you the correct answer now?
Sure.
It's 57,000. Response 4. So the inpatient hospitalization, the average cost is $57,000. So moving forward, the bottom line is, I think that based on those facts and based on the amount of insurance dollars that are out there that are recoverable by hospitals, that a strategy around motor vehicle accidents needs to be considered. You need to look into it. And the reason for that is that there are 5 emerging trends we're going to talk about today that need to be considered. One, we're talking about specialty niches are increasing in value. And we're going to go over every single one of these in more detail moving forward, okay? But bottom line is your reimbursement rates on these specialty niches are higher, period. It's higher than self-pay. It's higher than commercial and government health insurances. And there's nothing you can do about the decrease on the government and commercial health side, and there's not a lot you can do on the self-pay side. So this, again, the specialty niches are the areas that you need to consider. Compliance risks are rising. You're looking at Medicare secondary payer concerns. You look at order of benefit determination concerns. You have to look at HIPAA concerns. All of this is costly. So in order to effectively manage the motor vehicle accidents, you have to also manage the compliance concerns around them. Patient satisfaction is paramount. I think that speaks for itself. In order to have to be successful, you have to have a happy patient, a patient who's willing to pay for the services that were rendered. There's specialized expertise. I can just go ahead and tell you, hospitals are so good at billing health insurance companies. You have systems that are built for it. You have employees that understand coding. You have employees that understand the billing side of it. You have employees that understand all aspects of billing insurance from a health insurance perspective. That being said, automobile insurance, bottom line, is a different animal. Billing no fault, billing liability, filing hospital liens, even billing work comp. It's all a little bit different than just going in, coding the claim, pushing the button, and electronically billing health. It's very manual, and you have to understand a lot of the laws around it as well. And lastly, the regulatory complexity is increasing. I see this every day. I get something called a listserv. I get a whole long list of cases every Monday morning that tell me any new law that's been proposed, any new law that has passed, or any new case that a court of appeals or Supreme Court has decided in all 50 states that revolve around hospital liens, coordination of benefits, accident claims, and I can just tell you that the first, let's call it 2 to 4 hours every Monday morning I spend reviewing case law and laws just around this subject matter alone, in order to stay up to date on it and in order to know exactly what's going on. And that complexity is increasing, because anytime you have a bunch of attorneys that are involved and they're trying to make more money for their client, which results in more money for themselves, you're going to have creativity that presents itself as far as trying to manipulate the system in some form or fashion. So you need to be on top of all of the regulatory changes that are occurring. So let's talk about the fact that specialty niches are increasing in value. The bottom line is reimbursement rates on those specialty niches, as you see right there, liability and no fault. On liability dollars, and these are numbers taken from, these are sample numbers taken from a random hospital system that we have, you're looking at 78%, at 78 cents on the dollar. Now let me tell you what's important about that. 78 cents on the dollar on liability payments, just the way our process is set up, we only pursue, I can't say only, 90% of what we pursue is self-pay dollars. The other, we'll call it 10%, those percentages may be off, but the other percentage of the liability that we collect is our own government payers, our government beneficiaries, where the government plan dictates that liability is primary. So that being said, you're looking at that 78% compared to the 3, 4, 5% you would get if it were self-pay, compared to, we'll call it 15 to 18% you would get if it were a government payer. So that's a significant pickup. On the no-fault piece, we're looking at an average of 61% reimbursement rate. That's compared to commercial, government, and self-pay. So as you can see, those are significant. Now, I'm going to go ahead and throw this plug in there again. Most of you don't track these type of metrics or these key performance indicators. And most of you have one financial class when it comes to auto insurance. It's either called auto or liability insurance. But I can tell you that they're two different types of insurance. It sure would be helpful if they could be tracked differently, because they're billed in different orders as well. And even Medicare wants you to bill them differently. But nonetheless, from the value perspective alone, the value proposition on this is, guys, go out there and compliantly bill that liability and compliantly bill that no fault, and look at the increase in value you get from a reimbursement perspective. Oh, I forgot that was on there. Treat MVAs as a separate financial class. So now, compliance risks. You have to comply, right? Medicare secondary payer compliance. I have an hour-long presentation on MSP compliance as it pertains to accident claims. It's terribly boring, but nonetheless, you have to comply. Once someone walks into your ED and they're involved in a motor vehicle accident, you have no choice but to comply with those MSP regulations. You have to bill that no-fault insurance. I'm going to give you a little tidbit here for those of you that are actually taking notes. I know how these webinars are, by the way. I've been on several myself, so I'm sure some of you aren't listening, but this is your cue to listen. Free information. Chapter 2, Section 60 of the Medicare Secondary Payer Manual addresses no-fault insurance. That's MedPay and PIP. For all of you who should be in Tennessee, we have MedPay here. It addresses that no-fault information. Chapter 2, Section 40.2 addresses liability. So, any rate, that's your little free tidbit. But then you have COB provisions. Guys, we have liability versus no fault and commercial health. And some of you say, well, again, auto insurance is auto insurance. We're going to file this lien. We're going to go out there. Well, let me assure you that you need to be sure that you're doing it in a compliant manner. Liability, no fault, and commercial health. There's hold harmless clauses in a lot of your commercial health policies or contracts. There's case law out there that says patients can be third-party beneficiaries of that payer-provider contract. And as a result, hospitals that haven't been honoring this have been involved in class action suits. And that has resulted in what we'll call meaningful damages. Let me give you an example. There's a hospital in Louisiana. I'm not going to name the hospital, but it is an acute care hospital for the most part. It's a 52-bed, I believe, 52-bed facility. A number of years ago, they were filing liens inappropriately, and they were refusing to bill commercial health. And I'm not going to go into all the details surrounding the background of the case, although I will say, that, at least from a lawyer's perspective, it was very interesting. The hospital ended up initially being, basically the case was found against them for doing that. They had to pay $17 million in damages. Now, for some of you sitting out there that are with these huge systems, $17 million, while it's a lot, may not be significant. Here's what you need to know. That was $17 million on a hospital that did an annual, their annual, the gross patient revenue, GPR, is $25 million. So $17 million is significant to someone whose annual revenue is $25 million. Now, once it was all said and done, that verdict was reduced down to around, I believe it was $7 million, but that was still a significant amount. So know that if you're not doing this right, there are some compliance risks that are out there, and you could end up being on the wrong side of a class action lawsuit. Patient satisfaction. I can't say it enough. We're aware of it. We're seeing it. We're hearing our hospital clients talk to us about it. We're seeing increased patient responsibility. Even though we have more patients than ever that are insured, we're seeing those high deductible plans. Those high deductible plans are ending up showing or resulting in significant patient responsibility on the back end. So you've got to engage the patient beyond just the clinical aspect, and you've got to be able to talk to that patient about what does your insurance coverage look like? Were you involved in an accident? Your patient access is so important. When someone comes in and you're facing that patient for the first time, you've got to ask the right questions. And one of those questions is, was this injury accident related? And then you have to find out, who is your automobile insurance? Who are, were you at fault? That sort of thing. Then you have to map the entire patient experience to make sure that you understand what occurs at each touch point. Every time someone talks to that patient, know what that means and make sure that they're asking the right questions. And then lastly, you need to align yourself with organizations, for those of you that outsource, with partners who serve as advocates for your patients, both on the clinical side and the financial side. And again, partnerships are becoming incredibly important. So, as I talked about before, on the NVA patient accounts, patient access teams have to receive ongoing training. Our experience has been that that area of the hospital or the ED is the area that has more turnover than any other area. And as a result of that, ongoing training is essential. You have to make sure that your patient access people understand and know on these MVA accounts to ask, is it accident related, and who is your insurance carrier? again, the patients have to be educated. The patients have to understand that there are other insurances out there that are available to them. A lot of them don't even know or understand that they have MedPay or NoFault. And we're going to talk about what that means in a second, what the definition of that is. But they don't even understand that they have that type of insurance to even pursue. And the Medicare beneficiaries, I'll just go ahead and tell you, you better be completing the MSP questionnaire at the point of registration. And those questions are in your MSP questionnaire as far as, was this accident related? And then it jumps you into who those insurance carriers may be, if in fact it was. Then you need to look at the KPIs. Those are key performance indicators. You need to establish those KPIs and you need to monitor those. Basically, it's metrics. You need to look and make sure that you're tracking the right numbers and that they look like they're supposed to. Now, I'll tell you that as far as the NVAs are concerned, that hospitals are tending to partner with outside vendors. Out of the 10 largest health systems out there, 7 of them actually outsource to a vendor to handle their NVAs. There are 3 full-service rev cycle, consolidated business office type companies out there. 2 of those 3 have a partner that they contract with to handle their NVAs. And the reason for that is simple. Guys, the reason for that is just simply because there's so much around this that makes them more complex than most realize. Lastly, regulatory and case law changes are consistent in the healthcare market. So in this specialty reimbursement area, as far as motor vehicle accidents is concerned, we're seeing a lot of case law. And again, I told you I get those listservs that come out every Monday. A couple of great examples and how just nuanced and crazy these cases are. Shands Teaching Hospital versus Mercury Insurance Company. Florida, this was a case in Florida with Shands. And it all revolved around the constitutionality of the lien law in the particular county that Shands is in. So Florida has a unique lien law in that it allows counties to have a lien law on a county-by-county basis. There is no state lien law per se. Where the court landed on this is basically, if it was a county ordinance, then it was constitutional because the county had the ability to pass that law and it was upheld by the Constitution. If it was a special law that was not passed by the county but went through the state legislature, then it was in fact not constitutional. So then we had to go through on behalf of our Florida clients and do an evaluation on the constitutionality of the lien law within their particular county. Needless to say, that was quite an exercise, but that just shows you the nuances that can be involved when it comes to a case. Another one that probably, or that should hit home for you all, is West versus Shelby County Healthcare. This case came out last year, I believe, and basically it revolved around whether or not a hospital was properly utilizing hospital liens. And I'm not going to go into the details or the facts around it, but just know that that case has been significant. And what I think is more significant is that attorneys are using that case, plaintiffs' patients' attorneys, are using this case to try to get bills reduced. And I think they're using it incorrectly, to be quite honest with you, because this case had very specific facts and they're trying to incorporate other facts and utilize what we call dicta inside the case, which is just basically part of the language in the case that the judges used but didn't really impact the final decision. And so they're trying to utilize that case to decrease the amount that they pay out from their liability settlement. So you need to be aware of those types of cases that come out so that you can properly argue or debate, rather, with the attorney and get the money that you do deserve. So choosing to implement a strategy on motor vehicle accidents begins with determining whether you want to build an internal team or outsource to a specialized partner. Either way, you have to fully understand the scenarios and what's going on. As I told you before, this little niche is problematic, and I can tell you that there's not as much automation around it as there is with health. Remember, I told you that you're really good at billing health. You can hit that button and bill that health, and you're good to go. As far as these other specialty niches, that's not the case. They're not as advanced as far as their coding and their billing is concerned. So I'm running a little low on time. I've got about 14 minutes left based on my watch, so I'm going to run through these pretty quickly. And my contact information will be at the end if you have questions. But this is just a quick little map that shows diagram that shows why this is all so confusing. And you see the 837 and 835s. You see that they don't always go back to the hospital. You see that M is for manual processes and things that have to be manually done and letters that have to be sent. And it just is a really kludgy process. So you have to understand internally that this is a very manual component, both from an investigation, a billing, and follow-up standpoint. And then from a payment posting standpoint as well, because a lot of times paper checks will come in. So secondly, it's important to understand the technical nuances of the various insurance types. No-fault insurance versus liability insurance. Now I'm going to go ahead and go walk through this as best I can. No-fault insurance is the patient's insurance. When the patient walks into your ED, they have no-fault insurance, and that insurance is primary, and it is going to pay regardless of who was at fault for the accident. It's coverage that pays medical bills up to the insurance limits, and typically those limits are around $5,000. This in Tennessee is an elected insurance. It's about 35 states have MedPay. There's also PIP, personal injury protection. In PIP states, which are about 15 states, that's mandatory insurance coverage that pays medical bills, lost wages, etc., up to the limits. Now listen to this. MedPay and PIP should be likened or akin to the patient's group health insurance. It is the patient's insurance and pays regardless of who was at fault for the accident. Liability insurance is insurance that is paid by the at-fault driver to the injured party for their medical bills and other injury-related expenses. Now, liability insurance covers the party that was actually at fault for the damages that they cause. Okay? So it's a third-party coverage. It's not a first-party coverage. You have to remember that both typically pay at much higher rates than traditional insurance, and that we are seeing that about 30% of all accounts that come in are paid in full. That's 100% of bill charges. You must have a good understanding of the state-specific laws that dictate the coordination of benefits. All right, I told you all about West. I told you about Shands. You need to know about the lien laws in the state of Tennessee, timeline and the process for filing. So there's a very specific process for filing these. In Tennessee, it has to be filed within 120 days from discharge, and if it's filed after that, it's not a what we call perfected lien. If it doesn't contain all of the information and it's not sent to all of the interested parties in the manner that that law specifies, it's not a perfected lien. And then after you do have a perfected lien, there's a payout formula that's out there. In Tennessee, you get one third of that settlement is reserved to pay all hospital liens. And then you have some legal arguments like the common fund doctrine, which, by the way, is not applicable in the state of Tennessee to hospital liens. It is applicable to subrogation, which you all don't have to deal with. But you have the made whole doctrine. You have all these legal doctrines that attorneys are going to try to argue to make you think that they should be paying less. Then there are some nuances with the MedPay and or PIP coverage provisions. And then you have to think about the hold harmless provisions in commercial payer agreements, in addition to the paid in full language. And some their bottom line is there are a lot of nuances when it comes to MVA accounts that you need to understand. Fourth, you need to ensure you track manageable KPIs. Those are key performance indicators. And track month by month, and then look back on a trailing 12 to make sure that you are trending in the right direction. So we're going to look at some suggested key performance indicators, and I'm really going to bust through these pretty quickly so that we can address any questions at the end, and then again my information will be there, but there are quite a few of these and they're just graphs, but I'm going to run through them really quickly. You want to track the number of identified accident claims. Again, you want to separate those so that you know how many accounts you actually have that are accident related. You want to track what are your gross charges on that so you can track what kind of reimbursement rate you're getting on those particular accounts. You want to look at how many accident insurance leads you're getting. How many leads, meaning how many leads are you getting, a lead being auto insurance information, health insurance information, and or attorney information. How many accident claims have you closed, and what is the corresponding reimbursement rate on those particular claims? What was paid by liability and what was paid by MedPay? Again, separating those from a financial class perspective, in my opinion, is very important. We saw this slide earlier, payments by recovery types and the reimbursement rates. So you want to know, I'm getting this much from commercial, this much from government, this much from no fault, this much from liability from a reimbursement rate perspective. Reimbursement rates by attorneys. If you track the attorneys, then you end up knowing which attorneys are working with you as a partner to make sure that they're getting, they're treating the hospital fairly. And you know, you have to work with them too in granting fair reductions, but it will help you track which attorneys are good to work with and which ones are not. Average age. Goodness gracious, age is so important, isn't it? I know that that's one of the metrics that you all really look at. So just from a best practices standpoint, know that your non-litigated, and underline that, your non-litigated auto claims should be resolved no more than 90 days and 45 days for all of your workers' comp. The litigated auto can take a little bit longer, but what we see on average is about 200 days. Again, I want you to think about something. You have an option on those liability accounts. Those are self-pay dollars most of the time. 95% of the time, 90% of the time, whatever it is, they're self-pay dollars. And you can drop it to your bad debt, send it to your bad debt vendor and get 3, 4, 5%, or you can wait 200 days and it makes your aging look a little bad, but remember it's only 2 to 3% of your total outstanding AR, and actually the ones that are liability on your higher dollar ones is less than that, and you can get a 78% reimbursement rate or more. So think about that, because age on these accounts is not always a bad thing. So wrapping up, I want to leave you with 3 points. Establish a process to identify MVA accounts. Train your patient access staff to ask the right questions. Train them to identify and understand and know what questions to ask and how to identify these motor vehicle accident accounts. Establish a process to compliantly bill these MVA accounts. Establish a process to bill that no fault. You're going to get more money. Establish a process to bill liability, but do it compliantly. Make sure that you're filing liens appropriately, only on those self-pay dollars and or on the government dollars, mainly on Medicare in the state of Tennessee, on Medicare accounts. Make sure you're doing that. Establish that process. And I'll go ahead and tell you and throw this in there. the MSP regulations mandate that you establish a process to ask the questions, identify those payers, and bill those payers before you conditionally bill Medicare. So you need to know, that's your second free tip of the day, you have to bill NoFault, no ifs, ands, or buts. That beneficiary shall take, in fact, the regulation says, shall take whatever action is necessary to open a NoFault claim. And if they don't, then you can actually bill the patient after you've billed Medicare with the proper condition codes. And then if there's a liability case, then you have to bill that liability case, and after 120 days, then you can conditionally bill Medicare. So you need to know you have to establish a process to compliantly billing VA accounts, if for no other reason than to comply with MSP regulations. And then track the progress, your KPIs, your key performance indicators on MVA accounts. That helps you know exactly how successful you are, and it helps you to be able to go to your CFO or your VP of patient PFS and say, you know what, here's how successful we are on these, and this is the additional cash that we're bringing in the door. So thank you so much for the time. If you have any questions, now's the time to ask. This is my contact information. I jokingly tell people that your first 2 questions are free. The third one, I'm going to send you a contract. But in all seriousness, feel free to reach out to me. If you have any questions, you can leave me a voicemail if I don't answer, or you can shoot me an email and I'll get back in touch with you. Thank you so much, and I'll stick around for any questions for 3 or 4 minutes.
Chad, we do have one more polling question.
Thank you for reminding me. My goodness.
You're welcome.
The last polling question, please.
Okay. The last question is, an effective strategy for managing auto accident patient accounts is important for which of the following reasons? You have compliance, patient satisfaction, increased revenue, traditional indicators of revenue cycle are no longer enough, or the last option is all of the above. And just remember that this is your last opportunity to answer a polling question in order to meet the 2/3 requirement to earn the CPEs. So I'll give it just a few more seconds. Okay, Chad, it looks like 100% said all of the above.
I think that's correct. That was
Okay.
amazing.
Yep. And let me see if we have any questions. There was one question that said, what is the source of your data slides?
I'm sorry. But what did you just say?
What someone asked what the source was of your data on the slides that you had.
You know, that's a great question. So I hate to say this. If you want to send that to me via email, I will forward that on. I didn't create this particular presentation, and there were no footnotes in there as far as where the data was derived. As far as the statistics at the beginning, I can tell you that as far as the reimbursement rates and that information, that was taken from actual data that we have in our data warehouse here at our company.
Okay, I don't see any other questions. So thank you again for presenting today, and just for the attendees, Mr. Powers' information is on the slide here, so if you have any other questions, you can direct those to him. And I hope that you will join us next month.
Thank you so much.
Thank you.
Bye-bye.
Bye.